A warm welcome to all our dental professionals joining our webinar tonight. It's hosted by the YDC as well as the ITI. I'm Dr. Robin Kearney. I'm the current YDC president, and I'll also be the host of this webinar tonight. End of last year, Dr. Julyan and myself actually had a chat about how we can create a link between the ITI and the young dentists. And I would just like to thank Dr. Julyan as well as the ITI Exco for actually arranging these incredible speakers for us and setting up the structure and the content of this webinar. I just gave them the topic that we are going to discuss tonight, and they basically did everything else. So I'm going to just say that we're going to do the questions and answers at the end of our webinar once the speakers are done presenting. And I'm going to just introduce Dr. Julyan, and then she will take over from me and introduce our speakers as well as our structure of this evening. So Dr. Julyan completed her dentistry degree back in 2012 at the University of Pretoria, and thereafter completed community service at the Port Elizabeth Military Base. In 2015, she completed a postgraduate diploma in aesthetic dentistry, and in 2017, she started her journey as a prosthodontic registrar at the University of the Western Cape. She graduated as a specialist prosthodontist in 2022 and has since established herself in private practice in Cape Town. Great, Dr. Julyan.
Good evening. Thank you so much for having us. I just want to quickly share my screen. Okay, so thank you again to Robin and to the Young Dental Council for hosting us this evening, and thanks ahead of time to my wonderful team for assisting me with the lecture that I'm going to be providing you guys with today. So the topic of the lecture is restoring a single posterior implant, part 1, specifically what a periodontist, prosthodontist, and dental technician want you to know. Now, if you're having a look at the image on the screen, you know, for us, a single implant restoration in the posterior site is a bread and butter for any practice. And it is seen as being a simple restoration. However, there are so many important aspects that are involved in completing such a restoration. The idea behind tonight's lecture is just to provide a general overview and give you a couple of tips and tricks and maybe pitfalls to keep in mind when completing a single posterior implant restoration. As you can all imagine, you know, each and every aspect of this lecture could be a lecture on its own. So this is entirely just based, just to provide a basic knowledge and a basic broad outline of the topic that is at hand. So before I go any further, I just wanted to quickly highlight the speakers that you will be hearing from tonight. So on the far left-hand side, we have Dr. Avish Jagathpal, who is a prosthodontist up in Pretoria, Gauteng. We then also have Dr. Johann Lochner, who is a periodontist here in Somerset West in the Cape. We also have Trevor, who is a dental technician and owner of FK Dental Laboratory in Durbanville, Cape Town. And then before we go any further, I just wanted to introduce myself a little bit more. So as Robin mentioned, I'm a prosthodontist. I'm currently working in private practice in Somerset West in Cape Town. I work alongside Dr. Christian Forster, who used to be, he's our past president of the Southern Africa ITI section. I'm also a part-time consultant in the postgraduate department in prosthodontics at the University of the Western Cape. I've been a member of the ITI since 2016, and since 2022, I have held the portfolio of the Young ITI on the leadership team of the ITI. I'm also co-director of the UWC ITI Study Club. So there's a lot that I've mentioned now recently about the ITI. Now, for us, we are so, you know, ITI is part of our everyday functioning, and it's our family that we're part of. but some of you may not know anything about the ITI. So I just want to clarify, what is the ITI? So the ITI stands for International Team for Implantology. ITI is a global organization that is based out of Switzerland. The objective of the ITI is to promote and disseminate knowledge about implant dentistry and the related fields. They also mention that their purpose is to provide comprehensive, quality education in implant dentistry and to facilitate cutting-edge research. A little bit about the stats with regards to the ITI. So currently, we have 23,000 fellows and members. This is worldwide. Also worldwide, we have more than 800 study clubs. Now, it's obviously nice to know what's happening in the rest of the world, but I think what's more relevant is obviously what's happening in South Africa, where we are all working. Now, in South Africa, we have 14 study clubs. And what's very interesting is the membership has doubled within the past year. So this shows that there definitely is a benefit to being part of the ITI and that many people are being drawn to this organization. So I specifically am more involved with the young ITI, and this is specifically members that are under the age of 35 years. Now, this does not, you're not kept separate from the rest of the ITI members. Okay, you still have all the benefits that are enjoyed by everybody else. It's just the idea is that event lectures and hands-ons are more tailored towards the needs of the younger dentists. And we try our best to tailor all of these courses to being something that you would take home, a good take-home message and something that you can apply in your practices every day. A big perk or a big part of the young ITI is to encourage you to be more involved with organizing as well as at speaking at events. And that is a big portion of what we are trying to achieve currently within the ITI. And a big aspect of the young ITI is also mentorship. So being a young dentist, it is always helpful to have a mentor, whether it be somebody within your own practice or somebody within an association to which you belong. Someone that can guide you, someone that's been through the things that you've been through and that has asked the questions that you have asked. So just to highlight what the ITI has meant for me. So the ITI has always been a place of learning. It's also a place of socializing with like-minded clinicians. And mentorship by more experienced colleagues has by far been the highlight for me. The ITI also motivated me to want to learn more and to further my studies. And that is why I ended up furthering my studies in the field of prosthodontics. Now, a big aspect of the ITI is our study clubs, and it's something that we are very proud of. Now, study clubs can vary in size depending on the area that they are located in. Small study clubs can be 8 to 12 people, whereas our larger study clubs can reach up to around 30, 32 people. Now, what is ideal about our study clubs that we offer is that it is still a very intimate event. It is small. It's not an event where you will feel overwhelmed. It's one where you will feel comfortable asking the questions that you want to ask and getting clarification on the topics that you are uncertain about. So that is, for me, the ITI study clubs are a place of learning, and you never have to worry about asking a silly question because there's always somebody that is willing to answer you and help you out. Now, just to show you a couple of the very nice venues that we have held our study club events at. Now, I'm a bit biased because I'm from Cape Town. So these are all Cape Town events. But I'm sure up in Johannesburg and KZN, they have just as nice venues. But yeah, we try to go to wine farms. Top right-hand side, you'll see is actually the rooftop area of the Silo Hotel. So it's very nice places to go, get away from your dental practice and learn something while looking at a nice view as well. So the general format of our study clubs that we offer are normally case discussions or lectures, and sometimes we do some quizzes as well to keep things exciting. The range of topics vary from surgical to restorative and sometimes something completely different. Recently, we had a speaker who is a forensic pathologist, and he spoke to us about everything that can go wrong in the dental chair. So under sedation, medical emergencies, those kinds of things. So we do try to keep it quite exciting for you all. There are, of course, CPD points per event. So you can definitely benefit from a CPD point for every time that you attend a study club. And what a lot of people don't know is that you can actually attend a study club up to 2 times without being an ITI member. So all you need to do is contact your local Straumann supplier or your rep and ask them who or where is your closest study club, who are the study club directors, and you can request to attend as a guest. This is a nice way to test the waters, to see what is involved in a study club, and to see whether you would be happy being part of such an organization. Typically, we have 4 study clubs per year, and one of these is known as our year-end function. Normally at the year-end function, we do have our formal lecture component as well, but we always have a fun activity. So if you have a look at the pictures on the right-hand side at the top, we've got our recent year-end function that was hosted with the Winelands and UWC Club, and we took the Franz Hoek wine tram throughout a couple of wine farms, and then we ended at a wine farm where we actually blended our own wine. So that's just something fun to get your mind off of dentistry after a long year. And then in the bottom image on the right-hand side, you can see they are actually doing a cooking class. So this was something that was incorporated into the KZN study club activity. And yeah, the feedback was very entertaining. So another aspect of our association is our congresses that we offer. These images are from our 2022 Congress that was held up in Johannesburg. The congresses, follow your typical lecture and theory format, as well as hands-on and breakaway sessions. Our next Congress will be in April next year, 2025, and that will be down here in Cape Town. So please keep your eyes peeled for more information on that Congress. I also just wanted to touch on Women in Implantology Network, or better known as WIN. So I'm not sure if any of you have ever heard of WIN, but basically WIN is a subdivision of the ITI, and it is targeted at the development and support of women in implantology. Okay, it is also, I just need to mention, it is not completely only for women. Men are welcome to join this organization or the subsection. But it is highlighting the growth and the development of the women in the implantology field. Now, on the left-hand side, you can see Dr. Sune Mulder van Staden. She is a periodontist here in Cape Town, and she is our South African WIN ambassador. So if you're having a look on the screen, you can see they highlight at the bottom several benefits to being a WIN member. And on the right-hand side, you can see, second from the bottom, free access to the WIN classroom. So that means by signing up to being a WIN member, you get access to certain ITI Academy content, which, believe me, you'll want to go and have a check and see what there is to have a look at. Below that, you also see that you do get a 20% reduction on your first year of ITI membership. Now, just to highlight, being a WIN member or signing up for WIN is completely free. You just go to the website, you literally enter Women in Implantology Network, and it gives you a tab that you can click on, and then you can become a WIN member. No charge, and there are many, many benefits. So I would definitely suggest that you look into that. Several of the events that we host here in South Africa have been breakfast events, and we advertise these as being Women in Dentistry breakfasts. And as you can see from the images, top in the middle at the top, there are some males, right? So it's not only a woman event. The idea is just that it is women speakers. So we like to give women that are maybe starting out in implant dentistry the opportunity to get up on a stage where they feel comfortable and they can get used to being in the limelight. It's really such a nice event. It's the organizing team always go to so much effort, and it's really, really nice to be a part of this. I want to just highlight, before we move on to our lecture, just a couple of upcoming events. So specifically the ITI curriculum foundation level. Now, I'm pretty sure majority of you have seen this on social media and have possibly heard of colleagues of yours that have gone through this curriculum. This is provides a broad theoretical base in your implant dentistry. All of the learning modules are 100% online, and they are complemented by a practical hands-on program. There are several orientation meetings, as well as weekly Thursday evening contact sessions, which are used to answer any questions and for mentoring. There are several contact sessions which are in person, first one being in July and the second one being in August, followed by the online examination, which is on the 28th of August. So what I would suggest is, if you wanted to further your implant knowledge, that you would take a screenshot of this page. You're also more than welcome to scan the QR code for more information on the ITI curriculum. Another event that is coming up is our ITI Education Day, and that is on the 21st and 22nd of June down here in Cape Town. We have two international speakers, being Chris and Maya, who are a father-daughter duo, and then we have our local periodontist, Jeff Patterson. So the format of the Education Day is, day one would be a full day of lectures, which is a combination of your surgical as well as your restorative aspects in implant dentistry. And then the second day is a half-day photographic course. So for those of you that don't know, Chris Chamelski is a master dental photographer, and he is coming to share his knowledge with us. So you definitely don't want to miss out on this event. And then just to add on to the WIN breakfast, we have this year got 2 events. Traditionally in the past, we have only had a single event down here in Cape Town. However, this year we have decided to offer one up in Pretoria as well. So on the left-hand side, you can see the Cape Town event is on the 17th of August. And then on the right-hand side, the Pretoria event is on the 1st of September. You definitely don't want to miss out on these. I will, at the end, provide you all with details as to how you can get more information on these events. Now, I'm sure you didn't all join just to listen to me talk. I am now going to pass over to my colleagues who are going to continue with the program for this evening. As mentioned previously, this lecture is meant to just highlight a couple of key aspects and to get you hungry for more information, which can obviously be provided by the ITI. I thank you so much, and I hand over to Dr. Johann Lochner for him to continue with his presentation.
Right, good evening, everyone. I am Dr. Johann Lochner. I'm a periodontist in Somerset West, here in the Western Cape, and I'm also a part-time lecturer at the University of the Western Cape, teaching on the registrar program. I am currently the ITI president for Southern Africa since 2022, and I really want to thank SADA for hosting us for this online event tonight. Thank you, Jennifer, for that very nice introduction to the ITI. I've been a member of the ITI for over 10 years, and it is like a big family of colleagues learning from each other. And after all, the main reason why we want to be part of such a global organization is it's all about evidence-based dentistry. And evidence-based dentistry is what's going to make your practice successful with less complications, happy patients. And I would really urge you to look at itiza.org for all more information on how to join. So let's get down to the topic for tonight. Restoring a single posterior implant. And more specifically, what I'm going to cover is I want to show you how I want you to handle a healing abutment and clean the implant site. I'm going to take the surgeon's perspective tonight, with my other colleagues being laboratory technicians and prosthodontists. So let's get straight into the topic. So the question is, I really want us to get right down to the bare basics. And the question is, for many of us, might be a stupid question. I mean, we're talking about implants, but what is an implant. And we all have different experience levels. I mean, some of us know nothing about implants at the moment, but I can tell you one thing. Before I started with implantology, I also knew nothing about the implants. So what is an implant? An implant is basically a screw that's inserted into the jawbone to replace missing teeth. And this implant acts as an anchor to retain either an implant crown, or it's used to stabilize any other type of prosthetics. You can see two implants in place here, and you'll see that there is a little bit of radiopaqueness above the implants. That's the soft tissue that you can see. So if you see this type of image, this is not an image that will make it, that will tell you that it's possible to take impressions to manufacture crowns. What this will tell you is that you need to refer the patient and that surgery would be required to uncover those implants. So what is a cover screw? These two implants that is submerged and covered with gum is sealed off with little screws. If those holes are not sealed off, blood will go inside the connection of the implant and it will cause infection while the implants integrate. So if implants are submerged, meaning if they are covered with gum, they will need to be covered with a cover screw. So what is a healing abutment then? A healing abutment is basically an attachment or space keeper that is inserted into the connection of the implant, and it creates a channel from the oral cavity into the implant connection or platform. Here you can see those two same implants that now all of a sudden have little, I call them mushrooms, little mushrooms attached on top of them, and that will protrude through the gingiva then for you to take impressions. So what is an implant crown? Here you can see an implant crown. An implant crown is a crown that is placed into or on top of an implant. And here you can see a screw retained implant crown on the two images there and one on the radiograph. Okay, so let's just take a step back. Tonight's lecture is not a lecture on implant planning. And in my view, implant treatment planning is the most important part of implant treatment that you need to master. That's where everything starts. But this is not tonight's topic. This is also not a lecture on implant placement surgery. Sorry. Again, these implant surgeries is things that I would suggest you get involved with later. But this is a lecture on basic implant restoration. And this is exactly where I would want you as young dentists to get started in implantology. If you start off with the high-end surgery, you're going to burn your fingers, and it is going to be a process that will put you back and not create confidence in your profession. So start with the basics. I want to focus on how you as a restorative dentist manage the patient when they arrive from the surgeon. So in my practice, I will send the patient back to you with a healing abutment in place. And with that, you will be then ready for action. So again, let's go back to what is a healing abutment. It's a space keeper, and it's there to give you access to the implant's platform. It is there to shape and support the soft tissue. And very importantly, every single implant manufacturer have different shapes, sizes, being lengths. They've got different healing abutments that can be triangular, for instance, for a canine tooth. They can be square, for instance, for a molar tooth. But each and every manufacturer has his different healing abutments. And each healing abutment then can also have different purposes. But again, that is another lecture on its own. So what do I want you to take into consideration when you see that patient that comes into your chair with the healing abutment in place? So firstly, do a visual inspection. Okay, so what I want you to look at is the shape and the color of the soft tissue to make sure that it is pale pink and to make sure that there is no signs of any inflammation. The second thing that I would want you to do is to take a radiograph. Now, here you can see a radiograph of the implant in place. But as obviously has been said many times by your radiographic lecturers at university, no single view really gives you all the information. Comparison is what is important. So you need to compare the current radiograph with the radiograph that was taken at the time of placement. So here you can see that there's no radiolucencies around the implant. You can clearly see that the radiograph of the current situation, which is the middle image, that there's clearly some bone remodeling that's taken place around the head of the implant. But in essence, that is what you would be happy to see. Another very important thing before you carry on now is to verify the time that has elapsed since the implant's been placed. So obviously, you must not touch an implant until it has been allowed to integrate, which is in general for between 3 to 4 months. Okay, here is a radiograph of an implant post-placement, and you can look at the date there. And here is an image of that exactly same implant, more or less 4 months later. And it's clear to see that there is changes around the neck of the implant, where the healing abutment and the implant attaches to each other. If you see something like this, this is out of the ordinary, and this is something that you will have to then send back to your surgeon so they can give further advice and manage accordingly. Okay, so what is next? What is extremely important is that you make sure that you clean the screw access hole inside the healing abutment. If you do not clean that debris out of the head of the healing abutment, firstly, you will not be able to attach your prosthetic driver to remove the healing abutment. And secondly, if you can get access to it, you might not engage it fully, and then you can strip the connection at the top, and it makes it impossible for you then to get that healing abutment off. So clean that out. You can use a pigtail probe, you can use a straight probe, and then for the more tenacious bits of debris, you can even go so far as to use an ultrasonic scaler. What I want you to do next is I want you to remove the healing abutment. There, the healing abutment comes off. And I usually wipe that healing abutment, rotating it into a little piece of gauze, and you can see what comes out of that healing abutment once you just clean it. That's blood that's been left inside the implant on the day of surgery. So clean that off. Then I disinfect the healing abutment. I use 2% chlorhexidine to do this. It's readily available, it's cheap, and I'm sure all of us knows what it's all about, a little bit of chlorhexidine. So wash it properly. And also wash the inside of the implant connection with a irrigating tip. Okay. Then what's very important next is to, once the healing abutment is removed, is to check the soft tissue well. Now you can see on that image that there is little bits of white debris stuck into that implant well. Those are actually small pieces of bone grafting material, but it can be other debris as well. It's essential that that type of debris is removed. I usually take a little cotton pellet and just wipe it off. If it's sensitive, you can dip the cotton pellet in topical anesthetic. If it's extremely sensitive, it is so important to clean this debris out that you must then rather numb the patient up than leaving debris like that. Otherwise, if that debris is left and you restore the implant, leaving that debris will cause perimucositis firstly and periimplantitis later, which periimplantitis then is associated with bone loss as well. Okay, so the next stage after that will be the impression taking, and that is what Avi is going to cover for you, but I'm not done quite yet. After the impression is done, I just want to cover quickly what I want you to do once that is done. So again, I want you to irrigate the internal connection of the implant again. And I then want you to replace the healing abutment. Now, this is extremely important, again, making sure that when you replace that healing abutment, that you apply a good vertical force and a turning motion onto that healing abutment. It is crucial that the healing abutment is secured correctly. Now, in general, it is said that we can all turn with some effort about 10 Newton centimeters with our fingers. But that 10 Newton centimeters value is not a reproducible number between colleagues. So what I would urge you to do is to use your torque wrench and make sure that that healing abutment is secured at no more than 10 Newton centimeters. Now, I don't want there to be any confusion with this, because there has been confusion in the past with with this type of thing, where dentists will then torque the healing abutment to 35 Newton centimeters, and that will cause you not to be able to ever get that healing abutment out of the head of the implant, and you can even lose the implant when trying to remove that healing abutment then. So extremely important, secure tightening with no more than 10 Newton centimeters of torque. All right, here you can see 2 implants submerged with gum over them, again with 2 cover screws. There you can see second stage surgery. And on that image, you can see the right side implant. There is a small discrepancy between the healing abutment and the implant. That means that that healing abutment is not seated. So I did some profiling, and again, another image. Again, that image shows that it's seating better, but you can still see a discrepancy between the 2 healing abutments. And finally, I got it to seat completely. That is what it should look like on a radiograph. It is essential that a healing abutment does not come loose after you have taken your impression or after you've done your surgery. This happened in my own hands, where I placed an implant on the left image on the radiograph. Then 4 months follow-up, as seen in my previous slides, you can clearly see loss of bone around the head of the implant. And then clinically, you can see what that bone loss has done to that implant. And this is before the implant is restored. So this obviously had to be redone. And guess who paid for the redoing? The person that made the mistake, who is the person giving the lecture. So please learn from my mistakes and make sure your healing abutments are secure and tightened properly. So take home message. Few points, extremely important. If you forget anything else, these are the important things. Make sure that you clean the healing abutment wells after you remove the healing abutment, making sure that there's no debris. Disinfect the inside of the implant and make sure that that healing abutment is secure and cannot come loose. And with that, I'm going to give over then to Avi. Thank you very much.
Hello. Okay, just get my screen going. Okay, so I'm Dr. Avish Jagathpal, and a lot of you people out there, I see a lot of familiar names on that list. So it's nice to see you guys. Well, nice for you guys to see me, I guess. And despite me being dressed as an undertaker tonight, I'm actually a prosthodontist, and I practice in Pretoria, and I am a part-time supervisor at the University of Pretoria, and I teach undergrad and a bit of postgrad as well. I have my own private practice in Pretoria, and I'm the president of the Academy of Prosthodontics of South Africa too. I'm the director of the Pretoria ITI Study Club, and we don't have a nice view like Jen, so we don't have winelands. So we drink papsak and things that come in boxes up here. But no, I joke. We do weird things like we play dodgeball for our year-end functions at our study club. So our thing was, if you can dodge a complication, you can dodge a ball. And so that's the kind of creative stuff we have to come up with because we don't have wine farms. I'm also the education delegate for the ITI Southern Africa section. So like the courses and stuff, my team plans that, of which Jennifer is a big part of. And today I've been invited to ask to single posterior implant. And so, look, if you consider down to bare bones, this little thing here, that's not what your patients want. They don't want the implant, they want the crown, they want the tooth, right? So the implant only facilitates anchorage of the crown. So all the stuff that Loki's talking about, critical, very important. But ultimately, patient doesn't want to see that implant. And if they're seeing that implant, we've got a problem. So let's talk a little bit about how we start getting a crown onto these implants. And, you know, very much like conventional dentistry, making a crown is enabled by us taking an impression. So this is the overview of tonight's discussion. We're going to talk a little bit about implant impressions, and hopefully you can get a grasp about the essentials of what you need to know about these implant impressions. In doing so, we will look at the most relevant points of creating a good implant impression in a way that's understandable and easy to follow. And hopefully you can take a few pearls from me here and there, just, you know, things that just might make your workflow a little easier. So let's start with what. What is a dental implant impression? So an implant impression is a three-dimensional negative recording of the oral anatomy. And this will then denote the future position of where you want that implant prosthesis. It's used to accurately relate the implant to its other structures in the arch, so like the teeth next door, the gingival profile, things like that. And we do this by connecting in precision manufactured components to the implant. And these are those components. There's a lot of them, but this is just a fraction of what's actually out there. There are millions of components around the world. And that can feel a bit intimidating. But it's these precise components that are used to actually give us the recording we need. Because remember, we don't take an impression of the implant. We're taking an impression of these little components. So it's technically an indirect impression. So to minimize the inaccuracies and irregularities of the impression, we need to ensure that there's a precision fit between all the components. So again, remember that there are millions of these available. So it's important to understand the workflows because a particular system will give you only one for a particular indication. So don't become overwhelmed and don't feel confused yet because any system can guide you easily on their workflows into which components are right for that particular implant and that indication. So a successful implant impression can be done in one of three varieties. It can either be indirect, direct, or a digital impression. Now, what these mean, I'll actually unpackage a little later when we cover how to take an implant impression. So now let's jump on to when. And like Loki has just shown us, we want to allow enough time for healing of the implant before we even touch the thing. So some surgeons will place a healing abutment directly onto an implant before they've even exposed the thing. That doesn't mean it gives you freedom to just take it off and start restoring it. You must give the mandatory 3 to 6 months before you can touch that implant. And this must be quantified. So there must be somebody that tests that implant and gives you an ISQ reading or implant stability quotient reading to say, this implant is ready to go. Now, you may have a circular healing abutment like the ones that Loki showed, or you could have a custom shaped one that has been customly made, or one that's come from a company that's got a custom shape to it. The other thing is that you've got to allow the soft tissue to heal enough. So once your periodontist or your maxillofacial surgeon, like Loki, has cut open that soft tissue, placed his healing abutment, and sutured it up, we usually give it about 10 to 14 days to heal properly before we actually go on to the impression taking procedure. Now, remember, this is for a very specific indication. We're not talking immediate loading and immediate placements and all of that. So that's a lot more advanced. We're talking about a healed site in the posterior maxilla or mandible, a basic entry-level restoration. So with these, we like to go for a staged approach. Let everything heal, move on to the next stage. Let it heal, move on to the next stage, and so on. So most importantly, this is critical. Always refer to the treating surgeon's report for the implant details so that you may know what are the correct componentry to order. If you didn't receive the report, contact the surgeon or the dentist that's placed the implant and request these implant details. And this is what makes ordering the corresponding components easy. Then you don't need to go through that entire list of what do I order? you start to get a little bit gray like me looking for componentry. It's quite easy if you know exactly what implant you have. Then you just pick up the phone the rep. This is the implant. This is what I need. I'm taking a direct impression. I'm taking a scan. I'm taking an indirect impression, whatever. And the rep will give you exactly what you need. Right. Why? Now, there's a few things under why. The first is, why do we need these precision components? Why are there so many components upon components upon components? And can't we just take a normal crown and bridge impression? And the answer is that the precision fit between these different parts means that the correct load is transmitted from the teeth down to the implant. And it's not just possible to take a normal elastomeric impression like crown and bridge and ask a lab to cast or mill us a component and still expect it to have the same fit within the implant. There's just too many variables that and too many inaccuracies built into that system that just ruins the whole fit of it all. And if there's a problem in the fit, there's a problem in the load transmission, which means that something's going to break. And, you know, when people start asking questions because things are going to break, and then they ask, why did it break? And then you've got to answer, I didn't follow the right protocol. Or you followed the right protocol and say, oh, I don't know. I followed the right protocol. Here's the steps. We did everything we needed to, and here's the proof of it. So, you know, it's those kind of things that you can say, I didn't do it right, or I did it right. So those are your answers. So the other thing is, why are there so many different types? And why doesn't every single implant company use the same component? And that would be, in an ideal world, that would be better. But this is not an ideal world, and more specifically, this is South Africa. So it's even less than ideal. But each implant company actually believes that they have the best connection in the world. Yes, every implant company believes that. And the thing is that different connections mean different things to us. They all achieve something different. You could have an external hex connection. You could have an internal conical connection. You can have a Morse taper connection. You can have an internal hexagon connection. And they all do different things. So look, this comes into the more advanced parts of implant planning. But for what it's worth, if you are comfortable with an implant, stick with it. Just know its limitations, know what's good about it, what's bad about it. And that applies to also the implant company and the implant's connections itself. And even remember that within one company, you may even find different types of impression copings. Some are for bone level, some are for tissue level, some are narrow, standard, wide, whatever. And that's again comes back to, with the surgeon, knowing exactly what the implant details are is critical, because then you can order the necessary component quite easily. And lastly, why are these impressions so daunting? I don't think we should be afraid of dental implants. And like Jennifer's just told you, the average dentist must be able to at least restore a single posterior implant crown. This is a non-negotiable. Don't refer me your single posterior implant crowns. Don't refer it to us. This is stuff that general dentists should do. This is as dentistry as a class 2 composite. So a lot of the guys who come out of dental school a little before the age of implantology, don't feel intimidated. Go out, do a course, learn how to do it properly, and come back and do it. It's simple. If you know what you're doing, you respect the anatomy, respect the biology, it's going to work easily in your hands. And trust me, in a lot of cases, it's easier than putting on a rubber dam. Right. So now we're going to get into the crux of it. And let's talk about how. So remember, we spoke about these 3 methods, and we're going to discuss them now. So indirect impression taking method is very similar to what we do in conventional crown and bridge. So we insert the indirect impression post, and then we seat our impression tray with our impression material inside, as we would a normal crown and bridge impression you see there. Once set, we remove the impression, and there it is. That's your implant impression, believe it or not. Simple, right? So we remove the coping from the implant, we connect it into the laboratory analog, and we just push it back into the impression, just like that. We fill it up with gingival mask, and so that's like a silicone type material to resemble the soft tissue, and with plaster, and that becomes our master cast. We remove the impression, we unscrew the component, and Bob's your uncle. We have a duplicate model that represents what the oral anatomy is like. Easy, yes? Okay, let's go on to direct. Now, the direct implant impression involves picking up a component fixed within the implant impression. So the component is seated into the implant and it's tightened with the driver. Notice the difference in shape in this implant component versus the previous one. This one's got a lot more undercuts, right? So if you notice that, that means that we're not going to be taking it out of this impression. It's going to destroy the impression if it comes out. So we want the impression to grab onto this impression coping and not let go. So we use an impression tray that's got a little chimney at the top of it. And this allows the coping to stick through it. And this is called an open tray. So what happens is we can access that screw channel from the top. So basically from outside the impression, we can access the screw and basically unscrew it. So here's a little image of a case that we did. So you see there's a little piece of wax that's covering our little tray where the implant impression would be taken. And then when we take the impression, this is what's left behind. So we unscrew the impression coping from the mouth and remove the impression tray, and this is our impression. Easy. Connect on a lab analog, and we follow exactly what we did with the previous situation. And here's a little case. There's a single implant in the posterior mandible. We're testing the fit of our impression tray. There's the impression with that little pin sticking through the improgram. We used the driver, unscrewed it, and picked up the impression. Quite easy, right? So the literature actually shows that this direct method of picking up the coping within the impression is consistently more accurate than the indirect. Indirect is quicker and easier, but take it from someone that's made all these mistakes. When it comes to implant prosthodontics, you don't want to be quicker and easier. You want to take the hard, tortuous route, because generally, if you tick more boxes, it means that you're doing more quality assurance checks. So in my mind, I prefer the harder route because then I'm paying more attention to detail. So here's what the final impression looks like when we connect on the lab analog. And a quick word on impression material. Which one do we use? There's three main ones in the market that we're going to use today. We'll use polyvinyl siloxane, we'll use a polyether, or the new impressions that we have on the market is called vinyl siloxane ethers. The literature shows that all of them are just as good. So there's no reason to pick one over the other. They will give you an adequate impression in no matter which one you use. Just a little word of caution when using polyvinyl siloxane. You know, most of you guys know it as light body and heavy body. And then when you hand them an improgram syringe, where's my light body, doc? So yeah, I go through that on a daily. That's my little pet peeve. So when you're using a polyvinyl siloxane and using the light body impression, be careful not to inject the whole material over the impression coping. What it does is, see that light body, it's too elastic. And if you allow too much of that material to set around your impression coping, the coping is not rigid enough in the impression. And so it can move a little. And then that leads to inaccuracies in your impression. So when you're going to use polyvinyl siloxane, only use your light body on the gingiva, not above that. Everything above should be with your putty or your heavy body or your medium body. Okay, so lastly, let's touch on digital impressions. So the literature shows that statistically insignificant differences exist between analog and digital workflows for a single unit implant restoration. So digital scanning is just as well accepted as a direct implant impression. So whichever one you prefer, go for it. And this specifically, I must just put in a little pin there, specifically for single units. It's going to become a lot more complicated when we talk about multiple units. But for single units, you can choose either one. So for this purpose, we utilize different implant components called scan flags or scan bodies. And these are usually made of PEEK, which is polyether ether ketone, or titanium. And typically it has a bevel or step on the occlusal aspect of it. And if you look at those yellow arrows, you can see that little bevel. So here's just an example. Well, two examples of scan flags inserted into the mouth. It's important to insert the scan flag and tighten it into position with the bevel or the step facing closer to the buccal. So as close to the buccal as you can get it within the rotatory anti-rotation hex inside the implant. And here we'll see a little video of a scan that we took. So an intraoral scan is retrieved and it's submitted to the lab via your cloud-based services, along with your integral details. And this is about the implant system, the crown material that you want, the shade, the contact strength, if possible, the type of occlusion that you desire for your restoration, the emergence profile. So these are all the things that you need to communicate with your lab. Now, if you absorbed nothing from this talk, you don't like the way I'm dressed tonight, you don't even like looking at me, forget all of that. This is the most important part. So if you absorb nothing, absorb this slide. So please retrieve a radiograph to verify that the coping has seated onto the implant completely before taking this impression. So if we're looking at the images on the left of your screen, you'll see a little gap forming between your implant impression coping and your implant. That means that it's not seated. And for reasons like Lochie has just mentioned, where you could have bone over there, or the alternative is it may not have engaged the anti-rotational device. So it could be seated in a way, well, so the screw could be in, but it could be sitting on top of the hex, and it couldn't be completely engaged within the anti-rotational device. So the first thing you do is slightly between your fingers, you just twist it a little, and you might feel it just clicks into position. And that's the most common problem. So if you just turn it just a little, you'll find its seat. Or if it's more serious and you find that there's some bone blocking you out, so take a radiograph, you turn it, nothing happens, take a radiograph again. Okay, need to refer to the surgeon. He needs to profile that bone to get that impression coping down. So what you want it to look like are the images on the right, where you see there's a smooth transition between impression coping and implant. And also remember that this is your legal document, because this is the proof that shows that your impression was accurate. Right. So ensure that your lab slip is filled in properly with your opposing impression or cast, and get ready to see how your implant impression starts to make a crown manufactured at the lab. See you guys now. Trevor, you want to take over?
All right. Avi, can you hear me? Can everybody hear me? Good evening, everybody. Just going to start sharing my screen here. There we go. There we go. Good evening, everybody. It's lovely to be here with you tonight. I don't have such an impressive CV as my esteemed colleagues have that I'm sharing the platform with tonight. But nevertheless, my name is Trevor Bath. I'm the owner of FK Dental Laboratory here down in Cape Town. And we mainly specialize in implantology. And I've also been a member of the ITI for the past 15 years and also an ITI fellow for about the past 3 years. So Avi, just on a side note, not too much wrong with having a bit of pup suck now and again. As long as that is not the only thing you're having, then it's all good. So let's get into, we've got quite a bit of material to cover, so let's get into the lab process of manufacturing a crown. And like everybody said, this is just a brief overview, just to give one an idea of what the steps are involved in the dental laboratory to manufacture an implant crown. Of course, one can really go in depth into a lot of these topics which I'm going to be covering. But like I say, this is just an overview, and hopefully everybody that's joined us will be able to take maybe 1 or 2 pointers home that will ensure things in the practice go a little bit easier. So let's look at the process. Right, so the lab process for manufacturing an implant crown is basically broken down into a couple of sub-steps. And we'll be taking a look and going through those processes in those sub-steps this evening. Right. So first of all, there's the administration phase, which Avi's just touched on a little bit. Then we have the scan, inspection, and preparation phase. So I'll be doing the digital lab flow tonight, in the sense that most of the work which we are doing at the moment in our laboratory, at least, is about 70% digital. So there's been a major shift from the analog to the digital. So it looks like everything is moving in that direction. So felt only the right thing to do is to cover the digital aspect of manufacturing a crown. Then we'll look at the implant alignment, the crown design, in other words, the CAD, computer-aided designing. And then we look at the computer-aided manufacturing, which is also called the CAM, and then the sintering process, ceramic finishing, and then finally the cementation of the crown onto whatever abutment we've chosen to use. Right. So let's get into the administration. Besides the standard info which you would normally supply your lab with, there's 3 additional pieces of information which the laboratory requires when doing an implant restorative. So we obviously need to know who the implant manufacturer is. We need to know what implant system it is under which that manufacturer is operating, because many manufacturers have more than one implant system. And then we need to know what the connection size is of the implant. Now, this might sound like trivial information, but this is actually crucial information for the laboratory. And the reason for that being is, when one sets up the administration of doing a digital restorative, the software needs to know exactly what manufacturer, connection, and system is being used in order to design the crown and give the proposal of the crown on the prescribed components which go with that system, connection, and size. If you have the wrong system, connection, and size, the crown will not fit on the relevant titanium bases which we normally use, and that will obviously cause a huge problem. So take your time, do the admin correctly, and don't just fill in implant crown on your lab slip, which I find a lot in the lab. Just, yeah, implant crown and then nothing else. No, we need the manufacturer, the connection, and the system. Right. So once we've done the administration part of setting up the digital restorative, we obviously receive a scan. So Avi would do his scanning like he's just showed you and send it along to us via the cloud or the digital portals which we use. And then obviously when these scans arrive in the laboratory, there's certain criteria which these scans need to adhere to, or need to be of a certain standard for us to be able to manufacture a digital restorative. So what do we look at when we receive a digital scan? The first thing which we look at is the contact areas. So there's a contact area on the lower premolar. Looks like a 3-4. Now, a contact area like that, we could still manufacture the crown, yes, sure. But the problem with that type of scan or that type of contact area, this yellow part here, is that is all generated data. And what I mean by generated data, when one does a scan, an intraoral scan, and you miss an area of scanning, what the software, or in many systems, what the software then does is it generates a surface which it thinks is the correct surface to try and close that hole. Now you can see on that generated data there that obviously the contact point on that tooth does not look like that. So if the technician had to manufacture a restorative with that type of, with the crown being in contact with that 3-4, one of two things are going to happen. Either the contact is going to be open in the patient's mouth, or the contact is going to be too tight. Inevitably, both scenarios is an issue, and probably the crown will have to go back to the lab if the contact's open, for the lab to add on that contact. If the contact is too proud on the restorative, then the clinician will sit down and spend a couple of minutes, or maybe sometimes even more than a couple of minutes, to get the contact perfect to be able to see the restoration. So make sure that the contacts where your restorative is mesial distal in the scan is correct. If not, take the camera, take your intraoral scanner, go and scan that area again and make sure that you have decent contacts. Here you can see the contact on that 1.7 or 1.6. That's what the contact areas should look like. No generated data, exact representation of the tooth as it is in the oral cavity. So that's what the technician would like to see. Right. So much so for the contact areas. The next thing we look at is the opposing dentition. So if we're working in the area of the 4.6, obviously the upper scan of the first quadrant is going to be insufficient for the dental technician to be able to manufacture any type of restorative accurately as far as the occlusion is concerned, because half of the first quadrant is missing in this intraoral scan. And yeah, once again, it's either going to be too high in the bite and you're going to spend hours having to grind the crown into the patient's bite, or it's going to be too low out of the bite and it will have to come back to the lab to add on or even to remanufacture. And then probably the one which I have the most problems with as far as the digital workflow is concerned is the bite check. So this is one which one really has to pay careful attention to. This is probably the most tricky scan to be able to get correctly, out of all the scans which need to be taken. So a nice trick maybe to check the bite with is before you do your intraoral scan, is let the patient bite down on some indicative paper, some bite paper which you would normally check the bite of the crowns with. Then do your two scans, your lower and your opposing scan, the upper and the opposing. And then once the software has merged the two dentitions into the occlusion, what you should then see is wherever the red marks have been, if you can imagine looking through the scan of the upper now. So we're looking at from the apical of the upper dentition. You can see that there where the red marks were on the lower dentition, they're actually protruding the upper dentition ever so slightly. So this would then indicate that the digital bite scan is the same as what the patient occluded when you took the articulation paper and made those red marks. So this would be a good indication that the bite scan which you have taken is correct. Obviously, a bite scan which is open or closed is problematic in the sense that either the occlusion is going to be too high, or again, one's going to have to do some additions to the crown to get the occlusion correct. So once all that has been checked, now we can actually start working on the scans in the sense of the first thing we have to do is clean them up. So this is what a normal scan would look like, which I would receive from Avi maybe. You can see there's quite a few defects in the scan itself. But what's important to note is the defects are not in any of the areas where one would want to do restorative. They're all at the gingival level. And that's not where we're working. So those defects will not matter and will not affect our restorative. Right. So once we clean up the scan, then the scan looks like that. So that's a lot better. So we clean up the scan for two reasons. It just makes it a lot easier for us to work on it. And number two is when we then have to print these digital scans and convert them to physical models on the 3D printer, it just makes a lot nicer and cleaner model for us to print. Right. So the implant alignment, and this is probably where Avish said, the most critical part for him is that making sure that the impression post is seated on the implant correctly. To me, this is also the most important part about any implant restorative is the implant alignment. So the scanning post needs to be free of major artifacts, holes, and deformations. So, like Avish already explained, there's so many different scanning posts out there. There's literally thousands. But each system has got their own scanning flag, but they all do exactly the same job. It can either have one face of orientation. It can have 2, 3, 4, but they all do the same thing. The scan post communicates the position of the implant in all 5 axes to the software. So that's the role of the scan flag or the scan post, is to indicate to the software where the implant is located in the right 3D dimensions. So most of them have a flat side. Avish already spoke to you about the scan post, so we're not going to go into much detail about this. The only thing which I might mention on the scan posts, especially the ones made from the polyether ether ketone, is they're not very radio opaque. They're actually very radio translucent, and maybe Avi can comment on that a little bit later. So to verify the fit of these polyether ether ketone scan flags in the mouth radiographically is really, really difficult. So when one uses these type of scan flags or scan posts, it becomes more of a tactile feel when the scan post is actually engaged. But I'll leave Avi, he's the expert on that part. I'll leave that for him to cover and to maybe give some advice on that. And of course, the scan post, the most important part is the orientation, or the flat, what I call the flat side. Now that gives us the orientation of the X. If we just go one slide back. So this part of the scan post there where the RC is located, that's the flat side, or the hex orientation marker. So if one does not pick up that flat side in your scan post, you can pick up the whole scan post. If you don't pick that up in your scan, the scan will not work. It will not give you the orientation of the hex. You can still manufacture a crown, but the orientation of the crown, and orientation of the hex will be completely unknown to the software. So make sure if you miss a part of the scan flag in your scanning, make sure it's not the flat side or the hex orientation side. Here you can see another scan flag. The whole distal side of the scan flag is missing. But this is not such a big problem, because there is still the other 270 degrees of the scan flag has been scanned, plus the most important part, the flat side or the hex orientation side, has been picked up in the scan. And there's probably a 95% chance that this scan would suffice to be able for the software to locate the position of the implant. Here you can see another scan, the scan post, exactly the same patient. The scan post on the left-hand side, as you're looking at the screen, is perfect. You can see the whole scan flag, you can see the flat side. The scan post on the right-hand side is a complete mess. That will have to be retaken, and yeah, we'll have to get the patient back in to retake the scan. So be very, very careful about the scanning. Always make sure that the scan post is scanned as good as possible. And yeah, very good tip from Avi is to always put the flat side as close as buckled as possible. Just makes it a lot easier for the scanner to be able to read the flat side. Right, so this picture, no, it's not going to work. That's the phone call I got from the clinician. Is this going to work for the restorative? The answer is no, it's not. So what happened here was, it was a clinician that does chairside restoratives, in surgery restoratives, and they thought they would give it a go to do the implant work. And then at some stage they decided no, they're not going to be doing it, they're going to be sending it to the lab. So the lab scan post and the chairside scan post is 2 different scan posts. So what they did was they inserted the lab scan post and scanned the lab scan post. But what they forgot to do was to delete the chairside scan post from the scan. So what the software ended up doing is basically merging 2 scan posts into one. And yeah, it didn't help having 2 scan posts, because it can't work. So that's also getting the patient back, retaking the scan, So, no. Then what's very important as well about the implant scan, because what one has to remember is that when one is scanning for implant work, most of the CAD/CAM systems out there, the model or the scan which you manufacture the crown on is a different scan to the implant alignment scan. Those are absolutely two different scans, and they are located into two different catalogs. So what the implant alignment scan does, it communicates the position of the implant to our manufacturing scan. So what that means is, so in other words, the two scans have to be perfectly aligned and merged into each other for the implant alignment scan to convey the correct three-dimensional position of the implant to the manufacturing scan. So I'll just have a... So if you look at that, there's actually two scans on here at the moment. You can see at the top right, the one's the implant scan, the other one is our model manufacturing scan. So it's a lot better visible if you turn it on like that. Now you can turn it on to a monochromatic mode. So the blue scan, that is the scan with the implant scan post in place, and obviously the gray scan is the one without. So what the blue scan is telling the gray scan is, I'll be manufacturing my crown on the gray scan. So the blue scan is telling the gray scan, this is where the implant is and this is the orientation of the X. But if these two scans aren't merged perfectly into each other, as one can see here, you can only see the gray model. You can't see any of the blue model coming through. So this tells me automatically that these two scans aren't merged correctly. Now, how much are they out by? Well, to be able to determine that, one has to do a slice through both of these scans in that direction. And there one can now clearly see those two lines representing the border of the one scan and the other line representing the border of the other scan. So whatever those two scans are out by, and it looks like it's more or less 0.5, 0.6 millimeters, which those two scans are not aligned perfectly with each other. Your crown is either going to be 0.5 or 0.6 millimeters too high or 0.5 or 0.6 millimeters too low. So it's imperative that those two scans are merged perfectly with one another. And this needs to be checked in the surgery, so that by the time that the technician gets it, that one knows that everything is perfectly aligned. So how do we communicate that the position of the implant between the two scans? So what the software does is the software generates a proposed or the digital implant scan, which is the one in blue, and obviously the scan post is on the model which is, or the intraoral scan. So now what one needs to do is one needs to tell the blue part where the brown part is, basically. And that's done as follows. So we put 3 dots on the blue part. We put the same dots on the brown part, and the software will calculate using an algorithm of best fit where the blue part fits best into the brown part. So what has happened now is, now for the first time, your model, which I'm going to be manufacturing my crown on, knows where the implant is situated. And there we can see it's put the analog on my working model. There you can see the model with no scan flag. So this is my working model. Let's put the implant in position. Right, so once we've got that, we can start with our crown manufacturing. Now, what one has to bear in mind is, up to this point, everything which has been done has just been a manipulation of data which has been supplied to the laboratory. We have done nothing. We haven't changed anything. We haven't added anything. It's just been manipulation. So if any of that data is incorrect, it has to go back to the clinician, and that data has to be recaptured. From now on, from the CAD part onwards, now the laboratory starts adding their data to the manufacturing process. And we obviously have a number of digital tools which we can put a crown in position. I'm not going to go into the details of crown design and all that type of thing. And then basically with the tools, we design the crown to the correct occlusion, make sure the contacts are right, make sure the tissue pressure is right, make sure the profile is right, and the crown will and then the software will eventually put the hole through the crown fuss for screw retained restoration. Now we're ready to send it off to the CAM. Now the computer-aided manufacturing is where the crown actually gets made. So there's many different materials which you can make our restoratives in. The most popular ones at this stage, and the ones I probably use 99.9% of the time in the laboratory, is the lithium disilicate class of materials and the zirconia oxide class of materials. There are many, many brands out there, but I'm not here to advertise anybody's brand at the moment. So those two materials are forming the bulk of what we're processing our implant crowns in. Right, and then we send our crown to our CAM software, which will allow us to be able to generate a file, which we were able to send to our milling unit to be able to mill the crown effectively. There you can see the milling unit milling it out of a puck of zirconia. That's the lower or the apical part of the crown. That's the occlusal part of the crown after being milled in the zirconia puck. Right, so once it's been milled, we cut it out of the puck and then we're ready to send it to the centering furnace. So here you can see a whole lot of restoratives lying on a bed of zirconia little balls. Because this is zirconia, it's overcut by 25% because it shrinks 20%. And these little balls just facilitate the crowns rolling during the shrinking process of the sintering. You can also note some crowns have got some red dye on the inside. That is a blockout which we use to block out the titanium base, which we will eventually cement into the crown. This is our sinter furnace. You can see down at the bottom, we'll be sintering at 1495 degrees and this is a 9-hour process. And after the 9 hours, the crowns come out with their respective colors, and they've obviously shrunk in 20%. Right, ceramic finishing. So coming out of the furnace, we obviously have the old traditional stains and glazes available to us to be able to characterize these crowns, because about 90% of the posterior crowns which you're doing these days is full contour, no ceramic layering. So we just do some coloring and some stain and glazing on them. What's very important on implant crowns is that we do not apply any glaze on any tissue contact of any surfaces being in contact with the soft tissue. Any surface of the crown not being in contact with the soft tissue will get staining and glazing. The crowns then go into a porcelain furnace, fire at about between 750 to 900 degrees for probably that's a 45-minute cycle. We might even push them through once or twice through that cycle if we don't get the required glaze which we want. And then a very important part of the ceramic finishing process is the polishing of the surface of the crown, which is in contact with the soft tissue. We do not put glaze on this area which is in contact with the soft tissue at all. Right, ceramic finishing, and then we would do the cementation after we've stained and glazed our crown. There's our titanium base. The first thing we do with the titanium base, which is obviously 99% of them are silver colored, we put it through an anodizing process, which takes about 3 seconds, and turn it into a nicer, more friendly yellow color fuss, so that when we do cement the crown, that we reduce the graying effect of the silver metal on the crown. We then it's a very bad photo, this by the looks of it, but if you can see there, right in the center of the crown, there's a piece of sponge on the crown of the abutment, the titanium base. There's a piece of sponge put in there to block out the screw hole. We then use a primer. So this is a alumina zirconia metal primer, so we can use it both on the crown and on the titanium base. Put that on both, allow it to dry for a couple of seconds, and then we usually cement with any self-adhesive, well-known, reputable brand of resin cement. While the cement is still soft, we take the sponge out of the screw access hole, and the sponge just facilitates cleaning out that whole screw hole perfectly. So there's no sandblasting down there or having to grind out cement or anything like that. The sponge just works fantastically well to get the cement out of that screw hole. Right, and then the final step is to work off this junction between the titanium base and the zirconia crown. There must be no residual cement in that interface area whatsoever. Residual cement is a recipe for bone loss and inflammation down at the bottom there. So one must ensure that junction between the titanium base and the crown is absolutely perfect. So once we've done that, we're basically ready to send it out and put it in a bag and give it to the driver and have it delivered. And with that, I would like to thank you for your time, and I would hand you back to Jennifer or to Robin, whoever's going to be taking over.
That would be Misa. All right. So yeah, you mentioned a lot of big points there, and I think the one you were asking about peak. Yes, you are 100% correct. It's radiolucent. So that's why a lot of people prefer the titanium versions of the scan flags, because they can obviously see it on radiograph. But I think the newer generation of scan flags are going to be two pieces. It's going to have a titanium collar with a peak scan component, because the peak scans a lot easier than titanium does. But anyway, so look, let's talk a bit. I'm going to talk for about 1 minute on delivery. Okay, so we're going to get into delivery protocol. Literally, there's a lot to unpackage when it comes to delivery. And this is part 1 of the single implant crown. And I think that, look, I'll give you a brief summary of it, but even a brief summary is several points long. So the pretty lady that introduced us, Jennifer, twist her arm and tell her you want a part 2, and we'll unpackage delivery in a much more broader aspect. Specifically, one of the nice things is understanding why Trevor mentioned to keep the intaglio surface of the crown unglazed. That's a very interesting one, and you'd want to know why. So if you're watching on your phone or your laptop or your computer, just take a screenshot. This is your delivery protocol. I'm not going to go through everything in detail. We're going to just list through it. So you look at the lab work once you get it, check it out, make sure that it's clean. Like Trevor said, look for residual cement. If you have loops or a microscope, it helps even better. You unscrew the work from the cast, check the screw. Make sure that it is your final screw and not a lab screw. Some labs use brass screws. So make sure it's not one of the, it's one and not the other. You disinfect the lab work, and if necessary, you open your new packaging for your new screw. You remove the healing abutment from the crown, irrigate the implant with chlorhexidine, like Lockie has mentioned. You seat the crown, again, verify that it's fitted within that anti-rotational device. You hand tighten the screw, then you take another radiograph. Again, you've always got to verify the seating, and that is your legal documentation to prove that you did it right. You check your occlusion and contacts. So if the crown is not seating, check your contacts. Again, if you want to know how, we need to do a part 2. You adjust and you polish the ceramic, you torque tighten the screw, and don't forget your PTFE tape. Don't use cotton wool. That's an archaic way of doing it. We don't do that anymore. It's back with manual gearboxes, and back with those dial phones where all that is in the past. We don't do that anymore. You seal it with composite resin. A nice way I do is I place a little glass ionomer base over my PTFE, because then it creates a nice yellow floor, so that when I pack with composite resin, it becomes very aesthetic, and you can do your composite staining and all of that. But again, more to discuss later. You recheck your occlusion, and you polish your restoration, and your patient's ready to go. Okay, so from myself, thank you very much for your attention. I want to hand you back to Jennifer. And again, if you want to know more, get in touch with her and twist her arm, and I'm sure she can arrange a part 2. Thank you, everyone.
All right, I just want to quickly share. We are almost at the end. Thank you all for your attention and for sticking around. I just want to again put up the slide about the curriculum. So I'm hoping that tonight's lecture highlighted several aspects for you, whether you are currently placing or restoring implants, or whether you are wanting to get into the restoration of implants. If you perhaps want to look at having some comprehensive implant dentistry training, specifically with a one-on-one mentorship program, then you definitely need to look at this ITI curriculum foundation level. You need to register ASAP. There are limited spots. They only take 25 candidates. And that the whole reason behind taking such a small group is to have that one-on-one interaction. So please take a screenshot of this slide or scan the QR code and get some more information on the curriculum. Then I would advise you to please go and have a look at our recently renovated website, which is itiza.org. On this page, you'll get the opening page, which has several different tabs showing you information on the curriculum, upcoming events, study clubs, all of that. So if you wanted to attend any of our Women in Dentistry breakfast, you wanted to attend our education day or get involved with the curriculum or a study club, please find your way to that website page and you'll find all the information that you need on that page. Specifically, just wanted to highlight that as a young dentist, meaning under the age of 35, or if you are a dental technician, a dental assistant, or if you're a postgraduate student, you get a reduced membership fee of €120. A good highlight as well that has been brought in this year is what we call rolling memberships, which means if you join now, you are not going to be paying pro rata till the end of the year and then lose out on several months. You will have an active 1 year of membership from the day that you join. So if you join today, then it expires yesterday in a year's time. So you have a full year to access all of the content that will be available to you. And then, like all of you do, keep updated on Instagram. I would suggest that you whip out your phone now, take a screenshot, or quickly go onto your Instagram and follow these 3 pages. This is your way of keeping up to date with what we are doing, the different courses, and different programs that are being offered with the ITI. And we obviously hope to see you at one of our study clubs. Come and join us, come and meet us and see what we're all about. But from myself and the 3 men on the panel, I just want to say thank you so much for your time. Thank you for spending your Thursday night with us. And I do hope you all have a good Friday and a good weekend ahead.
Okay, wonderful. Thank you, Jennifer, Avi, Johann, and Trevor for a very, very informative lecture. We really appreciate it, and we're really looking forward to a part 2. I think Jennifer and myself, she already mentioned something like that, so I think we're all very excited for it. We're going to take some questions and answers now. Everybody, please feel free to ask questions. We are here to learn. Yes, Avi.
Sorry,
you said,
there were 3 questions that I just want to respond to.
Yes, I saw them to you. Welcome to.
Yeah, so I see that the one is the longevity of PFM crowns on an implant better than zirconium crown? So that's dependent on the clinical situation. PFM is not a dead science. It's still a very well, it's still indicated in many instances, specifically with longer spans where flexibility is needed. So we know for a fact that your pulse-infused metal is much more flexible, has a higher flexural strength than your zirconia, which has a lower flexural strength. So your zirconia can be very brittle in thinner profiles, and that's why you need a lot of thickness of zirconia to be strong. So PFM is not, it's not better. It's just a different indication. It's easier to get PFM. It's not easier. It's easier to get zirconia aesthetic, obviously, because you know what the opacity issues with PFM. But with longer spans, I would say zirconia and PFM, it depends on how much of interocclusal distance you have to make them strong enough. Why would scan bodies that are not very opaque? I think we unpackaged that a bit between Trevor and I. There are titanium scan bodies which are opaque, but the newer generation of scan bodies will have a titanium collar on them, so you will be able to see them. And there was one more. Oh, yes. Is it possible to explain impression technique to duplicate the emergence profile? 100%. So that's a step up from where we are right now. So this is just a basic delivery of, basic impression and basic delivery of a single crown. That is a very nifty, there's many techniques to do it, both digital and analog. But again, I suggest a part 2 where we can actually, and it's also complex. So you need time to actually unpackage the whole thing. So I would recommend a part 2 where you can delve into those, maybe even a part 3 to delve into some of those more tricky parts of implant dentistry.
Yes, it looks like we're going to have a part 1 to 20 with it when it comes to all the surgical complications. So we're into sinus lift questions now. Should I answer that question quickly?
Yes, please.
Okay, so the first thing comes down to treatment planning. If your case is planned properly and you've got a CBCT, the likelihood of perforating the sinus would be very low. So if you know where the sinus is, don't perforate it. Second thing is, if you drill into the sinus, it will heal within a couple of days, as long as you don't insert an implant then into that perforated sinus with the implant protruding into the sinus. What's actually interesting that even if you do that, the chance that you get an infection with an implant protruding into the sinus, as long as the implant is stable, is theoretically also unlikely, but that is not how it should be done. The implant should not be protruding or intruding into the sinus. Implant should be short of the sinus. If the sinus is in the way, the sinus should be either lifted with a vertical technique or internal sinus lift, or beforehand or during with a lateral window approach. So it is extremely unlikely that you're going to get sued during implant placement if you perforated the sinus, because it will probably just heal like a piece of skin. But no loose particles into a perforated sinus. If you perforate the sinus and then go and introduce bone grafting material into that site, you for sure are going to get an infection. The sinus does not like looseness, doesn't like loose particles or things drifting around. I hope that gives a couple of very brief pointers. Sinus lifting is complex. Obviously, I saw from all the attendees, it's not only young members, I also saw some of my previous classmates. I graduated in '96, so it makes me feel young being on the young ITI forum or a young SADA forum and seeing my young colleagues from 1996 there, nice guys. So yeah, a vast difference between experiences, obviously, in the group. There's also many more experienced colleagues that I went through the attendee list while I was looking there. So obviously, therefore, the question about sinus lifts, but that's not where you get started. You start off with treatment planning. You start off with basic implant restorations, work yourself up, and then attend relevant training courses to better yourself and to equip yourself with the right knowledge on how to do, for instance, sinus lifts or bone augmentations before you just do a YouTube video or 5 and think that you're going to be able to master the technique doing that. That's not so.
Okay. Thank you, Dr. Lochner. Do you mind answering that question? Is it acceptable to use alcohol to clean implant components prior to seating?
Yes, I can answer that one. It's actually an interesting study. There's no difference in the outcomes between cleaning an implant component with alcohol or with chlorhexidine. They compared those two specific things. I do not like to use alcohol, though. Because in theory, if it's a very strong solution, it can damage the very delicate fibroblasts into that implant well. What's also actually interesting that's become known is that chlorhexidine also actually damages fibroblasts. So I rarely use chlorhexidine rinses or any other type of rinse nowadays after surgery. I basically just leave things to heal on its own, because most of the damage in my experience comes from the overzealous use of a mouth rinse to theoretically stimulate or aid in healing. It's going to either heal or not. Using a mouthwash to rinse 5 times a day will destroy your implant site, will destroy your extraction site, because the crucial glue that the body produces, which is the blood clot organized from blood, is then rinsed away all the time. So that with regard to healing. I didn't read the question on the alcohol, but no, alcohol solution, I don't know which ones you would be referring to. Chlorhexidine, Corsidol, is chlorhexidine or with alcohol. Yes, you can use that if you've got that lying around. But we in general just mix up normal chlorhexidine solution without alcohol. But the antiseptic effect of the two compared to each other, with an alcohol containing chlorhexidine and a normal chlorhexidine, or just the alcohol-based disinfectant, theoretically, there's not a statistically relevant benefit with using the one over the other. They all work sufficiently enough. I mean, with healing abutments, we used to use a little bit of chlorhexidine gel rather than just, but nowadays, I'll be honest, I just rinse out the well with chlorhexidine solution. I don't use a chlorhexidine. We used to just put a little bit on the back of the hand, a little bit of gel, swoop the healing abutment in the chlorhexidine gel, and then put it into the implant well. I don't do that anymore. But it's feel-good dentistry. If you want to do it, do it.
Okay, wonderful. Any of our speakers see any of the questions that they would prefer to answer?
Yeah, I see a few there.
Okay.
So there's a question on bruxes tend to break zirconium easier. Not really. So look, zirconia is a great material, but it will behave so long as you treat it right. Same as any other material. You respect the material, you know its limitations, it will behave. I think the biggest problem with zirconia breaking is not respecting your connector widths. So if your connector is too small, that's where you'll see a fracture. Overzealous adjustment, so grinding that zirconia too much, putting too long spans, and also a very big one is not respecting your eccentric loads. So there's, I think Jennifer does a great lecture. A lot of us actually do lectures on implant occlusion. And implant occlusion teaches you how to design your occlusion so that you generate the occlusal forces and absorb them directly within the implant body themselves, and not allow too much of eccentric loads. Because remember that these are rigid structures. You've got a rigid material, which is your prosthesis, your crown. Then you've got a rigid titanium abutment. Then you've got a rigid screw. And then you've got a rigid implant. There's no periodontal ligament. There's no give. There's no shock absorption. So that energy, that occlusal force has to go somewhere. And if you're putting a lot of eccentric load, where's it going to break? That's the question, because that load has to go. So if you've got these steep cuspal inclines, you're going to break a cusp. Or you're going to cause so much of torsional stress that you're going to either break the crown, break the implant, or break the screw. So look, your question's not really specific, because like I said, if you respect the material, you use it in the right way, it will behave, even in bruxes. So you just got to know how to make it, how to use it. So narrow your occlusal table, freedom eccentric, short cuspal angles, things like that, that makes sure that your occlusal load goes straight down the long axis of the implant, so that you're not putting too much of lateral forces on your zirconia. I assume you're talking about a single crown. The other instances refer to much bigger spans, and obviously avoid excessive grinding of zirconia. So that was the zirconia question. If you're interested in the last tooth with an implant crown, what determines the size of the crown design? Your interocclusal distance? Yeah, it's just as much space as you need. But be careful, because when your crown height space exceeds, well, your sweet spot is around 12 millimeters maximum. When you exceed that, your talking force becomes so high that you're more prone to complications. So, in the old days, we used to talk about crown to implant ratios. Nowadays, we talk about crown height space or prosthetic space, because we now know that the talking force of an implant doesn't affect of the crown doesn't affect the entire length of the implant. It affects the first 1-2 millimeters of cortical bone. So if that talking force is so large because of this massive crown, then you're going to be prone to more complications. So if you keep your crown below 12 millimeters, chances are you're going to be fine. If you notice your interocclusal distance is greater than that, then, my friend, you need to consider either augmentation techniques or removable partial denture. And does the ITI offer the restorative course, just the restorative course? I think Jennifer can handle that one.
I see she's busy typing.
I was trying to type to get through the messages. So basically, I'm not sure if the delegate is referring specifically to the curriculum. I'm assuming so. And what my understanding is of the curriculum is currently we have the foundation level part of the curriculum, and that is aimed more at the restorative aspect. Whereas there will be an intermediate level that will be introduced soon, and that will also be communicated with people via our Instagram pages, just to specifically show what that will specifically include. But initially, the aim is to more attend to the restorative aspects of our implant restorations and not the surgical aspects. I hope that's correct, Dr. Lochner, right?
Yeah, it is correct.
Yeah.
I mean, the major problem, or no, it's not a problem. The fact of the matter is that we are the second year of running the curriculum. So at the moment, there's 22 or 20 delegates that's finished. So we will need more numbers to be able to roll out such a course. It is on the cards, but it's on the cards for future. We first need to generate enough delegates that would be interested in that type of course. So no, it will not run in South Africa for the foreseeable future. Only restorative based courses. Then to answer the other question, there was another one for me, the vile smell. Okay, so when you have a vile smell when removing healing abutments, let's talk about healing abutments first. That is because of debris that's been left inside that implant. So yes, you're going to have to do exactly what I said there in my presentation. You're going to have to remove the healing abutment, clean the healing abutment, rinse the implant inside, rinse it out with copious amounts of chlorhexidine, and then that should be enough to get rid of that smell. There's also a very big difference between different implant connections when it comes to this, where your old-fashioned, more butt finished or external hex type interfaces, they are more prone to be affected with the type of smell, because as the two connections, the implant crown and the implant meet together, when they go in function, there is a rocking motion, and that draws in bacteria into the connection. So when you remove those, you will have a smell that comes from it. That is less so with cone connection or Morse type connections, but you can also get that foul smell from them. And I often see that when removing one of those crowns, that the crown can be, for instance, loose. So if you drill open the access hole, you'll often find that when you put your torque driver in it, the crown will be able to be or the screw will be able to be turned loose with your fingers. That means that the implant crown itself has lost its torque. So again, you get movement between the components. It draws in bacteria, saliva, and it doesn't smell very nice. What's the best way to clean the implant supported crown? Scaler tip, metal, these other. I mean, the ideal thing is not to scratch that very highly polished metal that Trevor showed so very nicely on a beautifully designed implant crown and abutment. You would prefer not to scratch that metal. But more important than that is if you've got a patient with a high bacterial load and tartar, it is more important than cleaning the hard tartar off than not scratching the metal surface. So you sit between a rock and a hard place there. I must say, in my practice, I spend a lot of time nowadays removing prosthetics and making sure that those prosthetics are clean. I do it outside the mouth. So according to the patient's risk profile, how much bacteria tartar they've got in their mouth, if it's linked crowns or long span bridges, I would in general say I remove those long span bridges, or patients with a higher risk of periodontal disease, I remove those implant prosthetics after a 5-year period, and then I see what sits underneath. If it's nice and clean and if there's nothing sitting there, then I'd go for a longer period. To go and dig at it blindly I don't really recommend that. So and that's why I'm a very big advocate of screw retained crowns rather than cement retained crowns, because the retrievability of a screw retained crown makes it easy to just undo the screw, take it outside the mouth, clean it, and put it back. And if you do that, the chance that you scratch that subgingival part of the metal or other part of the crown type of material is far less. You also have the opportunity then to make sure that it's highly polished. I don't know if anybody else wants to add anything extra on that.
Yeah, and remember that when you remove the crown, every time you loosen and retighten that screw undergoes torsional stress and fretting wear, and the screw gets weaker every time you redo it. So a good idea is when you deliver the crown, you need to tell the patient that it's going to be like a car and they need to service it every year. And after every 5 years, they need to start changing the tires. So you change the screws. So that's a nice way to just prep them for if screws start to get loose and if screws start to break, at least you know. So you can maintain that crown, take it off, replace it, or major prosthesis for that matter. But at least you prime them that those screws will undergo fatigue and they will need replacement too.
Okay, I think that then concludes our webinar for this evening. I don't see any more. Do you guys see any more questions? We have a compliment there. Thank you for a very informative lecture. Anything else? I don't see anything there. Okay, thank you once again to the ITI for a very, very good lecture. We really appreciate it, and we're looking forward to our 2.0 and hopefully 3 and 4.0, like Dr. Lochner said as well. And yeah, thank you once again, and you guys should have a lovely evening further.
Thank you so much for having us. Appreciate it.
Pleasure.
Thanks. Have a good night.
You too. Bye.